We are going to have our discussion on the large intestines. The portions, the parts of the large intestines are the cecum, the appendix, the ascending colon, the transverse colon, the descending colon, sigmoid colon, the rectum, and the anal canal. So these are the parts of the large intestines. The anal canal, you're going to go and read about it on your own from Snell's and Moa's textbooks. So our schematic diagram is here. The cecum. Remember last time we looked at the small intestines and we said that the ileum is the last part of the small intestines and joins the first part of the large intestines, known as the cecum at the iliocecal junction. So that is our cecum. Attached to it is the vermiform, worm-like appendix. After the cecum, we go to the ascending colon. That's the ascending colon. And this bend when the ascending colon is turning to become the transverse colon is known as the right colic flexure. The right colic flexure. Flexure is a bend of the colon. A bend. When you add colic, it's a bend of the colon on the right. Then that is our transverse colon. And then there is a bend here known as the left colic flexure, where the transverse colon continues with a descending colon. A point to note, the right colic flexure is slightly lower than the left colic flexure. Here we have the right lobe of the liver, which is big, maybe it pushes it down. Then we'll have our descending colon, which connects with a sigmoid. This curved one is the sigmoid colon, and the sigmoid colon connects to the rectum, and the rectum connects to the anal canal. The primary function of the large intestines is to absorb water and electrolytes, and we shall see the glands which are located within its mucosa. And stores undigested food, because we saw digestion was taking place in the small intestines. So the cecum is the first part of the large intestines, and this part of the large intestines is located in the right iliac region. You remember the regions of the abdominal wall. It receives the opening of the vermiform appendix and also the opening of the ileum at the iliocecal junction. And it is covered by peritoneal membrane. And when peritoneal membrane is covering abdominal contents, we call it visceral peritoneum. The junction between the ileum and the cecum, which is known as the iliocecal junction, has a valve known as the iliocecal valve to control the entrance of ilio content into the cecum. And on average, it is 6 centimeters in length, the cecum. I have already talked about the right iliac fossa, where it is located. The point where the appendix, and I repeat, the point where the appendix attaches to the cecum is known as the root of the appendix. The point where the appendix attaches to the cecum is known as the root of the appendix. And the appendix attaches at the cecum at its root posteromedially. on the posteromedial aspect of the cecum. That is where the appendix attaches to the cecum, and that attachment, we call it the root of the appendix. Now, peritoneum, as it is folding to reflect itself onto the cecum, it forms potential spaces. Those potential spaces, whenever we say a potential space is a space which can accumulate with the pathological content. Pathological fluid can accumulate there. An abnormal structure can herniate there. So it's a potential space. It can contain tissue or fluid. So when peritoneum is reflecting itself onto the cecum, it creates potential spaces known as recesses. There is what we call the superior ileocecal recess. It is above the point where the ileum joins the cecum. That's why we call it superior ileocecal. Then there's what we call the inferior ileocecal recess, below the junction between the ileum and the cecum. And then the retrocecal recess. Retro means posterior. So there's a space posterior, a space inferior to the ileocecal junction, and a space superior to the ileocecal junction, which are produced as a result of peritoneum reflecting itself onto the cecum and their potential spaces. So this bullet is talking about the length, the region of the abdominal wall where it is located, the root and where it is attached, and the peritoneal folds creating potential spaces known as recesses. Now, we saw that the muscula propria of the GIT contains the inner circular muscles and the outer longitudinal muscles. Now, when it comes to the colon, the parts of the large intestines known as the colon, we have the ascending colon, transverse colon, descending colon, and sigmoid colon. When it comes to those parts of the large intestines, of course, including the cecum, when it comes to those parts of the large intestines, longitudinal muscles do not surround the entire wall. Longitudinal muscles do not surround the entire wall of the colon. But those longitudinal muscles group themselves into 3 bundles only. So whenever you're moving around the entire wall of the large intestines, the colon plus the cecum, you're going to find the longitudinal muscles in only 3 positions. And in those 3 positions, the longitudinal muscles will form bundles. So those bundles of longitudinal muscles along the colon and the cecum are known as the tinea coli. So when you look at the word tinea coli, this is just the 3 bundles of longitudinal muscles which are located within the wall of the large intestines. The meaning of this is that whereas in the small intestines, the longitudinal muscle layer surrounds the entire wall, in the large intestines, that's the colon and the cecum, it is only found in 3 regions, forming bundles known as tinea coli. And the circular muscle layer for it continues surrounding the entire wall. And you're going to find that this longitudinal muscle layer, when it contracts, the longitudinal muscle layer of the colon and the cecum, when it contracts at those 3 points known as the tinea coli, it forms circular structures known as circulations, which we shall see, which form or which make the wall of the large intestine rough. These 3 bundles of longitudinal muscles known as the tinea coli One is anterior, another one is posteromedial, and another one is posterolateral. So these two are posterior, but one is medial, one is lateral, and one is anterior. Now, when it comes to the appendix does not have the tinea coli, because these three bundles of tinea coli, when they reach the appendix, and this is very important, the three bundles of tinea coli located in the cecum and the colon, that's the anterior, the posteromedial and the posterolateral, when they reach the root of the appendix, remember I have already defined the root of the appendix. When they reach the root of the appendix, they converge and then form a continuous layer around the wall of the appendix, just as it was in the small intestines. I repeat, the three bundles of longitudinal muscles known as the tinea coli, the anterior, the posteromedial and posterolateral, when they reach the root of the appendix, they converge and once again form a continuous layer along the wall of the appendix, just as it was in the small intestines, where the longitudinal layer is located around the entire circumference of the wall, meaning that the appendix does not have tinea coli, because by the time they reach the root of the appendix, they fuse and form one continuous layer. This similar event occurs when the tinea coli reach the rectum. When the tinea coli reach the rectum, they also converge and then once again form a continuous layer, meaning that the tinea coli also, that the rectum also does not have tinea coli. I talked about the ileocecal valve, which guards the entrance of the ileum into the cecum and controls entrance of content from the ileum to the cecum. Now we go to the relations of the cecum. What is anterior to the cecum? What is posterior to the cecum? What is medial to the cecum has been indicated here. Remember, the appendix attaches to the cecum posteromedially. That's why it is medial. Posterior to the cecum, there are these muscles of the abdominal wall. You remember when we talk about the muscles of the abdominal wall on the posterior aspect, we talked about psoas muscle and iliacus muscle. These two muscles are muscles of the posterior abdominal wall, and they lie posterior to the cecum. Plus these nerves known as the femoral nerve. This femoral nerve, we shall look at it next semester when we're looking at the muscles of the lower limb, and the laterocutaneous nerve of the thigh. Cutaneous means skin. Thigh, you know where it is. So these two nerves, femoral nerve and laterocutaneous nerve of the thigh, plus these two muscles are the structures which are lying posterior to the cecum. And anterior to the cecum, you have the coils of the ileum and the abdominal wall. These are the relations of the cecum. The blood supply of the cecum, we shall look at its illustrations. There are two blood vessels. There is what we call the anterior cecal artery and the posterior cecal artery. These two are the blood vessels that supply the cecum. Anterior cecal artery, posterior cecal artery. Meaning that one supplies anterior surface of the cecum, the other one supplies the posterior surface of the cecum. They are branches of an artery known as the ileocecal artery, because this ileocecal artery supplies branches to the ileum and the cecum. That's why they call it the ileocecal artery. So the anterior and posterior cecal arteries are branches of the ileocecal artery. This ileocecal artery in turn is a branch of the superior mesenteric artery. And the superior mesenteric artery in turn is a branch of the abdominal aorta. The veins take up the same names, have the anterior cecal vein and the posterior cecal vein, which drain into the iliocecal vein, and the iliocecal vein drain into the superior mesenteric vein. You remember that the superior mesenteric vein will confluence with the splenic vein at the portal confluence to form the portal vein. So anterior and posterior cecal veins, which drain into the superior mesenteric vein by the iliocecal vein. The cecum is made up of smooth muscle. That's why it's supplied by the parasympathetics through the vagus nerve and the sympathetics through the sympathetic trunk. And last time I said that lymphatics are studied because disease can spread through lymphatics. And these lymphatics always move along the arteries. Where the arteries branch from, that is where the lymphatics are going to go, because they are moving along the arteries. So if the blood supply to the cecum is coming from the superior mesenteric, because you remember superior mesenteric giving off the iliocecal and the iliocecal giving off the anterior and posterior cecal. So the lymph is going to go up until it reaches the superior mesenteric nodes. Those are the nodes moving along the superior mesenteric artery. And because the superior mesenteric artery is coming from the aorta, lymph will continue up and drain into the nodes of the aorta, known as the aortic nodes. So we are having our ileum there, forming a junction with the cecum, the iliocecal junction. And here we are seeing the iliocolic artery, or they can call it the iliocecal artery, giving off branches, anterior branch and posterior branches. We shall see them very clearly when we come to the appendix. These branches are the two anterior and posterior cecal arteries going to supply the cecum. And they are coming from the iliocecal or iliocolic artery. That is the entrance of the ileum into the cecum, and is guarded by the iliocecal valve. And below, about 2 centimeters below, we have the opening of the appendix into the cecum. So the cecum receives both the opening of the ileum and the opening of the appendix, which are approximately 2 centimeters apart. They are approximately 2 centimeters apart. The appendix, which is attached posteromedially to the cecum, is worm-like and long. It has a wall which is made up of muscle, and it is a lymphoid structure. It is envisaged that the appendix contains useful bacteria and also produces lymphatic fluid. Contains lymphatic tissue, which is very important in enhancing the immune system of the gastrointestinal tract. And those useful bacteria or normal flora are very important in cleaning the gastrointestinal tract. On average, the vermiform appendix, vermiform means worm-like. Vermiform appendix is between 8 to 13 centimeters. Attached to the cecum posteromedially. That is why we say it is the medial relation of the cecum. The entrance of the appendix and the entrance of the cecum, which we saw there, entrance of the cecum are the iliocecal junction guarded by the iliocecal valve, and this is the entrance of the appendix into the cecum. They are on average 2.5 centimeters apart. They are on average 2.5 centimeters apart. And this point where the appendix attaches or opens into the cecum That point there is known as the root of the appendix. And this tip is what we call the apex of the appendix. So these two openings of the ileum and the opening of the appendix are 2.5 centimeters apart on average, and the one for the appendix is below the one for the cecum. The appendix also has a mesentery. Peritoneum peels off from the abdominal wall and suspends the appendix. So this appendix has a mesentery. And the mesentery of the appendix, or the mesentery suspending the appendix, is what we call the mesoappendix. Inside this mesoappendix, we have the appendicular artery and the appendicular vein, which are supplying and draining the appendix simultaneously. So here we are seeing our appendix, and we are seeing this mesentery peeling off from the ileum to suspend it, and this mesentery is known as the mesoappendix. And it contains the artery known as the appendicular artery on its way to supply it. Here we are seeing one of the tinea coli converging at the root of the appendix. The others are posterior, posteromedial and posterolateral. They also converge there, and then they become continuous again throughout the whole of the appendix. So this is showing us how peritoneum reflects itself onto the cecum and the appendix. The space there is known as the superior ileocecal recess. The space below there is known as the inferior ileocecal recess. These are the potential spaces I talked about. And then the posterior ileocecal recess is posterior. The posterior, we cannot see it here, but because it is lying posterior. Then here we are seeing part of the peritoneum of the ileum peeling off to form the mesoappendix to suspend the appendix, within which we have, in the mesoappendix, we have the appendicular artery coming to supply the appendix. These are some of the sonographic images of the appendix. This is the longitudinal view. This is the longitudinal view of the appendix, and this is its wall. That is its lumen. And when you make a cross section through it, you're going to see it there. The inner content, the lymphoid tissue, is what we are seeing there. And the wall is what we are seeing there. This wall can be measured. The diameter can also be measured. When this appendix is diseased, it enlarges. So the normal diameter is known and the abnormal diameter is known, so they can be measured, especially when you have a clinical condition known as appendicitis. So on ultrasound, you'll be able to know, to appreciate, and to see the appendix. This is its longitudinal. You can see its tip there, and its root is down there. And then when you make a cross section, this is its cross section, the wall and the inside, and it can be measured to identify its diameter. And I say that when it is damaged or inflamed, it enlarges and its diameter widens. They will show you the normal diameter and the abnormal diameters, which can indicate disease of the appendix on ultrasound imaging. Like the cecum, the appendix is located in the right iliac fossa. And when you want to mark its surface anatomy, the surface anatomy is the estimate of where the appendix is located on the anterior abdominal wall. It is in the right iliac fossa. So the appendix is in the right iliac fossa. It is in the right iliac fossa. But if you want to estimate the position of its root, because I've talked about what the root of the appendix is, if you want to estimate the position of its root on the anterior abdominal wall, its root is what we call, it's located at McBurney's point. I'm going to show you where McBurney's point is located. This McBurney's point is a surface landmark for the position of the appendix. And below it, when you make an incision at McBurney's point and you go deep into the abdomen, this point is going to lead you to the root of the appendix. And I said that if you want to locate the root of the appendix, McBurney's point, or remember I said that the tinea coli converge at the root of the appendix. So if you open someone's abdomen, you look at the tinea coli and you follow them where they converge, that is the root of the appendix. Or if you have not opened the abdomen and you want to estimate on the abdominal wall, McBurney's point, which I am going to show you. So this point is known as the McBurney's point. This point on the pelvic bone is known as the anterior superior iliac spine. These points are known as the anterior superior iliac spines. They are points on the pelvic bone anteriorly, anterior superior iliac spines. And here we have our umbilicus. So the McBurney's point is on an imaginary line on the right, on the left. No, not the left, on the right. McBurney's point is on the right, on the imaginary line between the anterior superior iliac spine and the umbilicus. So how can this line enable me to identify McBurney's point? I move 1/3 of the distance up. 1/3 of the distance up from the anterior superior iliac spine along the line between the anterior superior iliac spine and the umbilicus. You move 1/3 of the distance up, and at that point, deep to it, you have the root of the appendix, and it is known as McBurney's point. When you make incisions there, you will go deep and see the root of the appendix. McBurney's point is the surface landmark of the root of the appendix on the anterior abdominal wall, and it is in the right iliac fossa. Now, the appendix is not always hanging down. The appendix is not always hanging down. The appendix is only fixed at the root. And we said that the root of the appendix is on the posteromedial aspect of the cecum. That root is fixed. But its body might be found in different positions, as we are going to see, because the appendix body is not found always hanging down. So the McBurney's point is there where the appendix attaches to the cecum posteromedially, and that is where we have the root of the appendix. However, as you follow and as you're seeing, the appendix might be lying posterior to the cecum. When the appendix is hidden posterior to the cecum, we call it retrocecal. So those of you who scan the appendix, don't expect that the appendix is always going to be hanging down in the pelvis. It can be hidden posterior to the cecum, and that is very difficult to see, and it's known as retrocecal. It can be lying anterior to the ilium, and this is known as pre-ilio. Pre-ilio. It can be lying posterior to the ilium, and that is known as post-ilio. It might be hanging down in the pelvis where most people expect it to be, that is the pelvic appendix. It can be below the cecum, and that's what we call subcecal. And it can be on the sides or lateral to the cecum, and that is what we call paracecal. These are the different positions of the appendix, so that when you are scanning it, you don't presume that it's always hanging down in the pelvis, but the root remains fixed irrespective of the position. The appendicular artery is the principal artery which supplies the appendix. This artery is very, very important, because if it is blocked, blood supply to the appendix is going to be cut off, and the appendix is going to begin breaking down, leading to a painful and emergency situation known as appendicitis. This artery must supply the appendix with blood. If it is blocked, the appendix is going to die off, and it's usually painful, and I will tell you how that pain comes about. So this appendicular artery is the one which moves through the mesoappendix that we saw. It is a branch of the ileocolic artery, and the ileocolic artery is a branch of the superior mesenteric artery. The vein is the appendicular vein, which drains into the ileocolic vein, and the ileocolic vein is going to drain into the superior mesenteric vein. For the lymphatics, they always move along the arteries, and they move up to where the artery is coming from, and they are going to join other lymphatics. So here we are seeing the superior mesenteric artery coming from the aorta. It gives off a branch, and this branch is known as the ileocolic artery. The ileocolic artery divides into a superior division and an inferior division. This inferior division is the one which is going to give off our anterior cecal and the posterior cecal, which we talked about. Then the inferior division of the ileocolic artery is going to give us our appendicular artery, which is going to come and supply the appendix. And it also gives off the branches to the ileum. So the subappendicular artery is a branch of the inferior division of the ileocolic artery, and the ileocolic artery is a branch of the superior mesenteric artery. And this is the blood supply of the appendix. The appendicular vein is going to go and drain into the ileocolic vein, and the ileocolic vein is going to drain into the superior mesenteric vein, and you see the superior mesenteric vein will go up until it is joined by the splenic vein to form the portal. So the appendicular vein drain into the ileocolic vein, and then they drain into the superior mesenteric veins. That is the venous drainage of the appendix. And remember that the ileocolic vein and appendicular artery move within the mesoappendix. And now when they are operating, when they are going to surgically remove the appendix, they first get these blood vessels and ligate them. To ligate is to cut and tie, so that they do not just make incisions and blood will pour out into the peritoneal cavity. And the blood supply is very important in the maintenance of the good health of appendix, without which it's going to get damaged or inflamed, a condition known as appendicitis, which is a very big emergency, and it's also very, very painful. This appendix nerve supply is very important, and I want us to appreciate this very, very importantly. It has smooth muscle, so it must be supplied by sympathetics from the sympathetic trunk and parasympathetics from the vagus nerve. That is because it has smooth muscle, and these are the two divisions of the autonomic nervous system which supply smooth muscle. However, the sympathetics are coming from T10 segment of the spinal cord. Now, this is very important. The sympathetics are coming from T10 segment of the spinal cord. Hope people are listening to this. The sympathetics are coming from T10 segment of the spinal cord. Now, T10 segment of the spinal cord, also, that is where the skin around the umbilicus gets its supply from. The skin around your umbilicus gets its sensory supply from T10 segment of the spinal cord. That is the skin around your umbilicus. When you touch your umbilicus and you get those sensations, they are coming from T10 segment of the spinal cord. At the same time, the sensory supply or the supply to the sympathetic supply to the appendix is also coming from T10 segment of the spinal cord. Now, remember one thing, that the autonomic nervous system is not sensitive to pain, but skin is sensitive to pain. So when the appendix is inflamed or damaged, when the appendix is damaged, those impulses of damage or stretch are taken to T10 segment of the spinal cord. And then they are picked by the sensory nerves going to the skin over the umbilicus. And when those impulses reach the skin of the umbilicus, you sense them as pain. That is why if you have appendicitis, inflammation of the appendix, you're going to sense pain around the skin of the umbilicus. Why is that pain coming to the skin around the umbilicus? The pain is coming from the appendix and it's going to T10 segment of the spinal cord. And then sensory nerves to skin are going to pick it from T10 segments of the spinal cord and take them to the skin around the umbilicus, because it is also supplied by T10 segment of the spinal cord. And because skin is sensitive to pain, you will sense those impulses coming from the umbilicus as pain. So when you have damage to the appendix, pain begins at the umbilicus, because the umbilicus shares the spinal cord segment with the appendix. And then it will move towards the right iliac fossa, but it will originate at the umbilicus. And that is how pain of appendicitis originates from, and that is the reason why. And I will show you an illustration to prove it. So here we are seeing the spinal cord, and this segment of the spinal cord is T10. The sympathetics of the appendix are coming from T10 and they are going to the appendix. But skin over the umbilicus is also supplied by T10, meaning that T10 segment of the spinal cord supplies both the appendix and the skin around the umbilicus. So when the appendix is damaged, the stretch impulses, because when the appendix is being inflamed, it enlarges, it stretches. Those impulses are picked and taken by sympathetic nerves towards the T10 segment of the spinal cord. And then these sensory nerves, which are coming from the same segment, are going to pick them and they are going to transmit them around there, and they are going to be sensed as pain. So the pain is, the damage is there, but the pain is taken to the skin around the umbilicus because they share the spinal cord segment. Why are we sensing the pain at the skin over the umbilicus, not in the appendix? Because the appendix is not sensitive to pain. So the skin, which shares the spinal cord segment, is the one which is going to sense that pain, because skin is sensitive to pain. And pain around there is going to indicate that maybe there is a problem with the appendix. It begins from there and then moves to the right iliac fossa, and it is so much. Why does it move to the right iliac fossa? because the appendix is going to also spread the inflammation to the peritoneum there, but it originates from the umbilicus for the reasons that I have given you. So appendicitis, inflammation or damage to the appendix, leading to pain in the right iliac region, which is known as acute abdomen, severe abdominal pain in the right iliac region where the appendix is located. When you touch the McBurney's point, when you press the McBurney's point, this person is going to sense a lot of pain. And that is as a result of inflammation of the appendix. Pain originates from the umbilicus and then radiates down to the right iliac region. How does it radiate? Why does it radiate to the right iliac region? Because on the inside of the abdomen, the appendix is also touching the wall of the right iliac fossa. So when it touches the wall of the right iliac fossa, that pain spreads to the right iliac fossa, but originates from the umbilicus for reasons I've given you. Enlargement of the appendix is going to block its lumen. Hyperplasia is increased cell division, which can block its lumen. And when the lumen of the appendix is blocked, whatever the appendix was producing is arrested there, and the appendix begins to enlarge and stretch. It can be blocked, its lumen can be blocked by fecal material, and that fecal material can prevent the secretions from the appendix, such that the appendix also continues to swell. So the secretions from the appendix are arrested because of blockage. This can be a piece of solid fecal material, or it can be cells which increase and block the lumen. And this content, the E. coli is very important bacteria, but they're going to accumulate there. And this accumulated content is going to cause the appendix to swell and lead it to damage, a condition known as appendicitis. A clot of blood may block the artery, and blood supply to the appendix is cut off. And when blood supply to the appendix is cut off, the appendix begins to die. And that can also cause it to weaken and rupture. And when the appendix ruptures, its contents pour into the peritoneal cavity and causes infections there. And that can also be a problem. And I've talked about how the pain of appendicitis is transmitted to the region over the umbilicus and then spreads down to the right iliac region, because the appendix shares the same spinal cord segment T10 of supply like the skin over the umbilicus. People with appendicitis who are assessing that pain, they bend. When they bend, the pain decreases, because when they bend, the appendix will no longer touch the abdominal wall, so the pain decreases. But when they stand, the appendix touches the abdominal wall in the right iliac fossa, and the pain comes back again. So they sense pain in the right iliac fossa, which originated at the umbilicus, and then when they bend, it kind of decreases, but when they stand, it increases. And the solution to appendicitis is surgical removal, a procedure known as appendectomy. They make incisions at McBurney's point, which will lead them to the root of the appendix, and they will dissect it out. That is our McBurney's point, where they make incisions. And this is where you're going to put the transverse. When you're scanning the appendix to go to the right iliac region, that is where you find it. Some people will move along the abdomen, the entire abdomen, looking for the appendix because they do not have the anatomy of the abdominal wall. They don't even know where the appendix is. They are using try and error to look for the appendix. It is in the right iliac region. You begin at McBurney's point and then you begin scanning. It is easy to see when it is hanging down in the pelvic, which we know that the pelvic appendix. But if it is hiding posterior to the cecum, retrocecal, it may be challenging to see. So that is the appendix. The next portion of the large intestines, we have looked at the cecum and appendix. The next portion is the ascending colon. And the ascending colon is located in the right lumbar region, and it is above the ileocecal junction. The ascending colon lies posterior or behind peritoneum. That is why we call it retroperitoneum. When we say retroperitoneum, it means behind peritoneum. When we say intraperitoneal, it means that the entire structure is surrounded by peritoneum, like the stomach. The stomach is intraperitoneal because it is surrounded by peritoneum, the whole of it. But the ascending colon is retroperitoneal because it is posterior to the peritoneum. Peritoneum just attaches to its anterior surface, but doesn't surround it entirely. So it is the ascending colon because it is moving up in the right lumbar region, and anterior to it will have these structures, posterior to it will have these structures. Remember the psoas muscle and the quadratus lumborum muscle, the muscles of the posterior abdominal wall. They lie posterior to the ascending colon on the right. The iliac crest is part of the iliac bone. And then these two nerves. You remember when I was talking about the abdominal wall, there was L1 nerve which gives off iliohypogastric and ilioinguinal. These structures are posterior to the ascending colon, and these ones, the abdominal wall, the coils of the ilium. Remember the greater omentum, which is peritoneum hanging down the greater curvature of the stomach. I talked about it. They are the structures which lie anterior to the ascending colon and it's located in the right lumbar region. So that is our ascending colon. And it goes on changing diameter. At its beginning, it is 8 centimeters. As going, it becomes 6 centimeters. In fact, for it is 6 centimeters in diameter on average. And in length, on average, it is 10 centimeters. Whereas our cecum is between 6 to 5 centimeters, the ascending colon is, on average, 10 centimeters. It from the region above the ileocecal junction to the right colic flexure. And we have looked at its posterior relations, the iliopsoas muscle, quadratus lumborum, ilioinguinal nerve, iliohypogastric nerve. We have looked at the anterior relations, the abdominal wall, and the coils of the ilium. And that is its length. So it begins at the region above the ileocecal junction and ends at the right colic flexure, stretching for approximately 10 centimeters in the right lumbar region. That is our ascending colon. The ascending colon is supplied by the right colic artery. This right colic artery is a branch of the superior mesenteric. The superior mesenteric gives off the right colic artery. This right colic artery is going to supply it. But also have a few branches from the ileocolic artery. The ileocolic artery supplies its first part, and then the distal part is supplied by the right colic artery, a branch of the superior mesenteric artery. And the vein is the right colic vein, which drains into the superior mesenteric vein. So here we can see the right colic artery supplying it, branch of the superior mesenteric artery, and the vein is the right colic vein draining into the superior mesenteric vein. So the ileocolic supplies its proximal part, and the right colic supplies its distal part, as we saw. The ileocolic supplies its proximal part, and the right colic supplies its distal part. Both of them are branches of the superior mesenteric artery, and the veins take up the same names. So here we are seeing the ileocolic giving off branches to the proximal part, and here we are seeing the right colic artery giving off branches to the distal part, and both of them are branches of the superior mesenteric supplying our ascending colon. At the right colic flexure, the ascending colon bends to become the transverse colon. And that transverse colon is between 38 to 50 centimeters in length. Between 38 to 50 centimeters in length. The greater omentum, that is peritoneum, which hangs down from the greater curvature of the stomach, covers it and fuses with it. It covers and fuses with it. So you have to lift the greater omentum to see the transverse colon. So on anterior aspect, you have the greater omentum and abdominal wall, meaning that you cannot see it when you open the abdomen. It is hiding posterior to the greater omentum, which also fuses with its mesentery. This transverse colon has a mesentery known as the transverse mesocolon. It is this transverse mesocolon which fuses with the greater omentum anteriorly, so that the transverse colon is hidden posterior to the greater omentum and you cannot see it. And posterior to the transverse colon, you have the duodenum. You remember the duodenum? The first part of the duodenum, we saw that anterior to it is the transverse colon. So posterior to the transverse colon, you have the duodenum, the pancreas, the coils of the ileum, and the jejunum. All these are lying posterior to it. Now let's look at this blood supply and we see it clearly. We have seen already that the ileocolic artery supplies the cecum, the appendix, and the proximal parts of the ascending colon. The distal parts of the ascending colon we saw were supplied by the right colic artery. Now what about the transverse colon? The transverse colon is supplied by the middle colic artery, and this middle colic artery, and this is very important, the middle colic artery supplies the proximal 2/3 of the transverse colon. The middle colic artery supplies the proximal 2/3 of the transverse colon. The distal third of the transverse colon is supplied by the branch from the inferior mesenteric. The inferior mesenteric artery gives off what we call the left colic artery, which will go and supply the distal third of the transverse colon. So, proximal 2/3 of the transverse colon, middle colic artery. Distal third, left colic artery. The middle colic artery is a branch of the superior mesenteric, and the left colic artery is a branch of the inferior mesenteric. So the junction between the proximal 2/3 and the distal third of the transverse colon, that's where we have the anastomosis between the middle colic and the left colic. I repeat, the junction between the proximal 2/3 and the distal third of the transverse colon, that is where we have the anastomosis of the middle colic artery and the left colic artery. Because the middle colic supplies the proximal 2/3 of the transverse colon, and the left colic supplies the distal third of the transverse colon. This anastomotic artery is what we call the marginal artery. The anastomotic artery between the middle colic and left colic is known as the marginal artery. How is this marginal artery important? If the inferior mesenteric artery is blocked, blood will come from the superior mesenteric middle colic, pass through the marginal artery and cover this gap, and vice versa. So this junction is where you have the marginal artery, an anastomosis between the middle colic and the left colic artery, which is very critical in maintenance of blood supply if one of the blood vessels to the large intestines is blocked. This junction is also the boundary between the midgut and the hindgut. So from the proximal third of the transverse colon onwards is the hindgut. And from this same point up to the duodenum where the common duodenal papilla joins, that is the midgut. So this is the boundary between the hindgut and the midgut, where we have the marginal artery, the anastomosis between the branches of the superior mesenteric, that is the middle colic, and branches of the inferior mesenteric, that is the left colic. So the transverse colon shares blood with the proximal 2/3 of the transverse colon. They get their blood from the superior mesenteric artery through the middle colic, and the distal third gets its blood from the inferior mesenteric artery through the left colic. That's the blood supply. The veins take up the same names like the arteries: middle colic vein, left colic vein. The left colic vein drains into the inferior mesenteric vein, and the middle colic vein drains into the superior mesenteric vein. That's the blood supply to the transverse colon. I've talked about the significance of this boundary between the proximal 2/3 and distal third of the transverse colon. So that's the point where I have the marginal artery, boundary between the proximal 2/3 and distal third. And then that is where the middle colic anastomosis with the left colic to form this critical point, which is the marginal artery, where we have our anastomosis. And this is the boundary between the midgut and the hindgut. And the veins, you can see the inferior mesenteric vein giving off the left colic vein, draining into the inferior mesenteric vein. And then the middle colic vein draining into the superior mesenteric vein. The transverse colon continues with the descending colon at the left colic flexure. And we saw it in our illustration, which we have this one. And say that the left colic flexure is slightly higher than the right colic flexure. That is the left colic flexure. The other name for the left colic flexure is known as the splenic flexure because it is below the spleen. And the other name for the right colic flexure is known as the hepatic flexure because it is below the right lobe of the liver. And this right lobe of the liver is the one which pushes it below to be slightly lower. And it's between 10 to 25 centimeters in length. It is also retroperitoneal, lies behind peritoneum, anterior to it, the coils of the small intestines, the greater omentum, and then the anterior abdominal wall, almost similar to the ones of the ascending colon. Posterior to it, you have the left kidney, and these two muscles of the posterior abdominal wall, these two nerves coming from L1, the femoral nerve, the altitudinous nerve of the thigh, and the iliac crest. These are the structures which are posterior to the descending colon, more than those which are posterior to the ascending colon. And it's also located in the left lumbar region. So the iliac bone is posterior to it. The left kidney, you can see it is posterior to it, and other structures, the muscles and the nerves. It is supplied by the left colic artery, which we have already shown you, which is a branch of the inferior mesenteric artery. So you can see the inferior mesenteric artery giving off the left colic artery, supplying the descending colon. This is the left colic artery, which goes up to the proximal third of the transverse colon, which I've just talked about. And the vein is the left colic vein, which drains into the inferior mesenteric vein. The sigmoid colon is the curved part, and it is located in the left iliac region, and it continues inferiorly with the descending colon. And we saw it here with its averages. These are average ranges, maybe adult, maybe young adult, depending on what they consider. It is this curved part of the colon, and it is suspended by a mesentery, also known as the sigmoid mesocolon. The mesentery of the transverse colon is the transverse mesocolon. The mesentery of the sigmoid colon is the sigmoid mesocolon. The ascending colon and the descending colon don't have mesenteries. And it ends at level S3, sacrovertebra 3, and that is where the rectum begins. So the junction between the sigmoid colon and the rectum is at sacrovertebrae 3. So it ends there. And its mesentery is known as the sigmoid mesocolon. Anterior to it, you have these structures, the uterus and the vagina upper part. Then the urinary bladder, these are anterior to it. Thus, urinary bladder is anterior to it in males. This is very important. The uterus and upper half of the vagina are anterior to it in females. The urinary bladder is anterior to it in males. Very important, and I usually use this for my multiple choice questions if you forget. Anterior relations of the sigmoid colon in males, urinary bladder upper part. Anterior relations of the sigmoid colon in females, uterus and upper part of the vagina. On the posterior aspect, you have the sacrum, the rectum, and the ileum coils. Its blood supply is the sigmoid arteries. Sigmoid arteries, which are branches of the inferior mesenteric artery. Let's get a better illustration, and we see this is the inferior mesenteric artery, and these branches are what we call the sigmoid arteries. They pass through the sigmoid mesocolon, which is around there. And the veins are the sigmoid veins, which drain into the inferior mesenteric vein. Sigmoid veins and arteries. So that is our sigmoid colon. And you can see some blood vessels, the ovarian and the testicular arteries passing posterior to it. The ureter also passes posterior to it. You can see it there. And then some nerves, like genitofemoral nerve, passing posterior to it. The sigmoid colon. Very important and significant. This is a complete blood supply to the large intestines. You go and look into it and appreciate it the more. Now, Tinea coli, I talked about them, that the longitudinal muscles along the colon and the cecum are grouped in only 3 bundles. Those bundles are known as Tinea coli. One is anterior, the 2 are posterior, posteromedial and posterolateral. And those are the ones we call the Tinea coli. When they contract, they fold the colon to make it rough, forming sac-like structure known as hostra because of the contraction of the tinea coli. So this is one of them, which is anterior, and this is one of the posterior, posteromedial, and another one is there, posterolateral. So when you look along the wall of the colon, you're going to see that there's a band of anterior, band of longitudinal muscles. This is the tinea coli, which is anterior. This is the tinea coli, which is posterolateral, and that's the tinea coli, which is posteromedial. The circular muscle layer continues. It's continuous along the entire wall of the intestine. Appendices, epiploicy. These are the fatty tags surrounded by peritoneum. They are fatty tags. They say that their function is unknown, but they are sacs containing fat, and they are mainly attached to the tinea coli. These are the fatty tags. Now, they may ask a question to distinguish between the large intestines and the small intestines. You have the large intestines with a large lumen, the small intestines have a small lumen. Tinea coli are present in the large intestines, they are absent in the small. We have appendices, epiploicy. These are the fatty tags. We do not have them along the small intestines. Now, and these sac-like structures which make the wall of the large intestines rough, these are known as hostra or saturations because of the contraction of the longitudinal muscle layer. All these are histological differences which distinguish the large intestines from the small intestines. Hostra, those are the folds, circular folds on the external surface of the large intestines due to contraction of the longitudinal muscle layer, which is in the tinea coli. These are the hostra, which make the surface of the colon rough, and we do not have these features in the small intestines. So you must have at least differences between large and small intestines, minimum of 10. On one side, you put large intestines, on the other side, you put small intestines, and you give a minimum of 10 differences. Then there is another one, differences between jejunum and ileum. I talked about it. Differences between large intestines and small intestines. You must give those structural differences. The wall of the large intestine is made up of the outer layer, which is the serosa. Then you have the muscula propria. You have the external longitudinal, which are in bundles, and the internal circular. Then we have the submucosa, and then the mucosa. The mucosa has the inner lining and the muscularis mucosa. And these are the glands, the tubular glands, which secrete mucus and within the large intestines. A point to note that the longitudinal muscle layer does not surround the entire wall, where we have the colon and the cecum. We also have a muscle layer in the mucosa, which is the muscularis mucosa, which participates in the folding of the inner lining of the mucosa, because sometimes it folds, and that is because of the muscularis mucosa. And our last part that I'm talking about today is the rectum, the most distal part. It continues with the anal canal. And the rectum, the purpose of the rectum is continence. Continence means to temporarily store. And its junction with the sigmoid colon is S3. It has two principal bends. The rectum has two principal bends. A sacral bend or sacroflexure and an anorectal bend or the anorectal flexure. And let us look at them. This is what we call the sacroflexure, following the concavity of the sacrum. Remember, this image is in sagittal section, median sagittal section. Whenever you're looking at an image, first find which section. It is female because I can see the urinary bladder there, the uterus and the vagina, and then the rectum is posterior. So the rectum, when it is following the convexity or concavity of the sacrum, we call that the sacroflexure. And then this other bend where it continues to continue with the anal canal is known as the anorectal flexure. Sacroflexure, anorectal flexure. Those are the bends of the sacrum. Now, this anorectal flexure is also very important. The one where the sacrum is going to become continuous with the anal canal is very important. It is maintained by this muscle known as puborectalis. Remember when I was talking about the pelvic diaphragm, I talked about a muscle known as puborectalis. Puborectalis contracts it and it closes, contributing to the temporary storage of fecal material. This is anorectal flexion. There are other flexures laterally. These are just in sagittal section, but there are other flexures laterally, as we are seeing. There is what we call the upper lateral flexure, the middle lateral flexure, and then the lower lateral flexure. The lateral flexures are seen in coronal section. The sacral and the perineal or anorectal are seen in sagittal section. I want you to appreciate this. The sacral and the anorectal or perineal flexures are seen in sagittal section, whereas the lateral flexures are seen in coronal section. The lateral one are the upper lateral on the right, middle lateral on the left, lower lateral again on the right. So it is bent in sagittal and in coronal section. So it is not straight. The rectum is not straight. It has lateral bends and sagittal bends. The bends which can be seen in sagittal are the sacral and anorectal or perineal. The lateral bends can be seen in coronal section. The ampulla is the widest part of the rectum. It is on the inferiormost aspect of the rectum, and this one holds feces before defecation. When you look at the inner lining of the rectum, the mucosa of the rectum, the inner lining of the rectum, it folds inwards at different positions. The inner lining of the rectum folds inwards at different positions. Those folds of the mucosa containing a core of muscle are known as rectal valves or Houston's valves. Rectal valves or Houston's valves. They are the foldings of the inner lining of the rectum. And these folds are semilunar in shape. And they are very important to lift the fecal material for temporary storage. When these folds are lifting fecal material, they decrease on the weight which the fecal material was administering or applying on the anal sphincters. So on the inner lining of the rectum, you have folds of the mucosa containing a core of muscle. And these folds are known as rectal valves or Houston valves. And they temporarily hold fecal material until you get the urge to defecate. The rectal valves are on average 12 millimeters in width. And on the inside, they contain a core of circular muscle lined by mucosa. They are usually 3, and we are going to see where they are located. The upper one protrudes from the right. The middle one protrudes from the left. And then the lower one protrudes from the anterior aspect of the rectum. The upper valves protrudes from the right, the middle one protrudes from the left, and the lower one protrudes from the anterior aspect, and they temporarily hold fecal material in the rectum before defecation, enhancing continence. So these are the folds. You can see it's made up of mucosa and a core of circular muscle. The upper, the middle, and the inferior. These are what we call Houston's valves. Very important. When they hold fecal material, the weight which was administered on the anal sphincters is decreased. And if these valves were not there, once you sense the urge to defecate, you just run to the toilet because the weight will be overwhelming on the anal sphincters, but they participate in continence. And they are very important within the rectum. So this is the sagittal section of the rectum in the males, or the pelvic region in the males, and this is the sagittal section of the pelvic region in the females. You can see in the males we have the urinary bladder and the prostate down there, urethra, then this space of peritoneal cavity known as the rectovesical pouch, and then the rectum. This is peritoneal cavity extending between the pelvic structures. Here we have the symphysis pubis, urinary bladder, rectovesical pouch, extension of the peritoneal cavity between the rectum and the urinary bladder. Vesicle for urinary, the word vesicle is for urinary bladder, rectal for rectum. So this extension of the peritoneal cavity between the rectum and the urinary bladder is what we call the rectovesical pouch. And then the rectum. After the rectum, you have the sacrum. And in females, you have the pubic symphysis, the urinary bladder. This space is what you call the vesicouterine pouch, the extension of the peritoneal cavity between the uterus and the urinary bladder. So you have the symphysis pubis, urinary bladder, vesicouterine pouch, uterus, cervix, and vagina here. Then you have the pouch of Douglas or rectouterine pouch, an extension of the peritoneal cavity between the rectum and the uterus, known as the rectouterine pouch or pouch of Douglas. And then you have the rectum and then the sacrum. And this is sagittal section. You can also observe these structures in transverse section. And that is how they are arranged. What is anterior to the rectum in males? What is anterior to the rectum in males? The rectovesical pouch, the sigmoid colon, the ileum, the urinary bladder, the prostate, and the seminal vesicle. Let's see. This is the rectum in males. What is anterior to it? The rectovesical pouch, the sigmoid colon, the seminal vesicles, part of the male reproductive system, the urinary bladder, the prostate. These are the structures anterior to the rectum in males. What is anterior to the rectum in females? The rectouterine pouch or pouch of Douglas, the sigmoid colon, the ileum, vagina, and the cervix. So this is our rectum in females. So we have this pouch of Douglas or rectouterine pouch. You have the uterus, the cervix, the vagina, and the sigmoid colon. Sigmoid colon, rectouterine pouch, uterus, cervix, vagina. These structures are anterior to the rectum in females. And these structures are anterior to the rectum in males. Very important relations, and here we have demonstrated them in sagittal section. You're going to find slides which demonstrate them in transverse section. The posterior relations are the same in both men and females. The posterior relations are the same, mainly the sacrum and the coccyx. There's a muscle known as piriformis, coccygeus muscle, we saw it in the pelvic diaphragm, levator ani muscle, we saw it in the pelvic diaphragm, and nerves coming from the sacral segment of the spinal cord known as the sacral plexus. These are the same relations both in males and in females. Blood supply to the rectum. The rectum is supplied by 3 arteries. The rectum is supplied by 3 arteries. The superior rectal artery is a branch of the inferior mesenteric artery. Superior rectal artery, branch of the inferior mesenteric artery. Then we have the middle rectal artery, a branch of the internal iliac artery. Have the common iliac dividing into external iliac and internal iliac. So the internal iliac artery gives off the middle rectal artery. And then the inferior rectal artery is a branch of this artery known as the internal pudendal. The internal pudendal artery also comes from the internal iliac artery. So the internal iliac artery gives off the internal pudendal artery. The internal pudendal artery is the one going to give off the inferior rectal artery. So the superior rectal, a branch of the inferior mesenteric, the middle rectal, a branch of the internal iliac artery, and the inferior rectal, a branch of the pudendal artery, which is internal branch of the internal iliac artery. This is the blood supply to the rectum, well supplied with blood. Veins, superior rectal vein, draining into the inferior mesenteric vein. The middle rectal vein, draining into the internal iliac vein, and the inferior rectal vein, also draining into the internal iliac vein. Blood in the superior rectal vein is going to go to the inferior mesenteric vein and it's going to finally end up in the splenic and portal vein. So this is portal blood because it will end up in the portal vein. Blood in the middle rectal vein and the inferior rectal vein are going to end up in the inferior vena cava. So this blood is systemic blood. So anastomosis between the superior rectal and then these 2 blood vessels, middle rectal and the inferior rectal. Thus, anastomosis are known as portosystemic anastomosis because this blood is going to the portal vein, this blood is going to the inferior vena cava. As I said that the lymphatics follow arteries, we are seeing the lymph nodes in between of the lymphatic vessels following the arteries up to where they go. And then it means that the disease in the upper aspect of the rectum is going to move through lymphatic vessels along the superior rectal artery. And then these ones is going to disease in the lower, the middle. You can see it's divided into upper, middle, and inferior portions. So this one is going to spread towards the superior rectal lymph nodes. Then the middle is going to spread towards the middle rectal lymph nodes. And then the inferior one is going to spread towards the inferior rectal lymph nodes. Cause lymph nodes move along arteries. Now the nerve supply to the rectum. Let us look at this before we conclude. Here I have said that sympathetics come from the lumbar splanchnic. Splanchnic nerves are branches from the sympathetic trunk. I repeat, splanchnic nerves are branches from the sympathetic trunk. And the branches of the sympathetic trunk, which are in the lumbar region, we call them lumbar splanchnics. These branches of the sympathetic trunk, known as lumbar splanchnic nerves, are going to form a network known as the superior hypogastric plexus and the inferior hypogastric plexus. Let us see. This is the sympathetic trunk. This is the lumbar region. You can see the lumbar spinal nerves. So these branches of the sympathetic trunk are what we call lumbar splanchnics. These lumbar splanchnics are branches of the sympathetic trunk in the lumbar region. They come down along the aorta and form a network there at the bifurcation of the aorta. Here we are seeing the aorta bifurcating into right common iliac and left common iliac. So that is where these splanchnic nerves form a network known as the superior hypogastric plexus, which will supply the superior aspect of the rectum. Then we are going to see them continuing down to form a network, another network on the lateral aspects of the rectum known as the inferior hypogastric plexus. So when I say that the sympathetics move through the lumbar splanchnic nerves and supply the rectum through the superior hypogastric and inferior hypogastric plexuses, that is what I mean. Those are the sympathetics. The parasympathetics come from spinal cord segment S2, S3, and S4. These are the parasympathetics. Spinal cord segments S2, S3, S4, they are giving us the parasympathetics. The lumbar splanchnics through the superior hypogastric and inferior hypogastric plexus give us the sympathetics. One of the there are very many importances of the rectum is the rectal examination, whereby they can pass a finger through your rectum and then on the anterior aspect, because I told you one of the anterior regions of the rectum is the prostate. So then if the prostate is enlarged, it can bulge the anterior wall of the rectum, and you can palpate it and assess whether it is enlarged or not. And this comes with having a proper understanding of the knowledge of the anterior regions of the rectum. You're going to go back and read about the anal canal in Snell's textbook and Noah's textbook to appreciate the structure of the anal canal, and we shall call it at that. So our next lecture